there are three cases. A couple of cases are the same, in which we can ask the audience to tell us what is the UIV and the LIV. So this is a 14-year-old girl and 2 years post-menarche, and this is her clinical picture. There is a right-sided thrust, the medial thoracic, medial shoulder level is higher, and that's how she looks. And this is a 60-degree thoracic curve with a 27-degree lumbar, and she's linky thoracic plus because she is 49 degrees from T5 to T12. And on bending, she comes down to 35 from 60 degrees, and the 27 lumbar goes down to 10. And this is the patient. And so what are the UIV and LIV? Could you take a round on the in the audience, or shall we proceed to some of the panelists?
Okay, someone would recommend the upper end and lower end vertebrae from the audience? T4 to L1. Any other opinion?
T4 to L1. So Baron and Ibrahim, would you go with T4 to L1 or T4
Another
to
opinion,
T12?
12.
Yeah,
Selective fusion.
I worry about, and it's great to be here with you on the panel, Ibrahim. I worry about the proximal kyphosis. So I think going to T4 is, a little bit low in this case, because you're going to end up with a junctional problem because you haven't incorporated all the kyphotic segments. So I probably would go up to T2 proximally, and if the touched vertebra might be T12, I would consider going to T12. If L1 is substantially touched, L1. I think it's certainly safe to go to L1, but you might be able to go to T12 in this case.
And Ibrahim, would you consider the
I
T12
totally agree
L1?
with I totally agree with Baran. It's perfectly. It's exactly what I want to say. So the patient has a upper thoracic kyphosis. I think we should not stop on T4 for sure. And for the lumbar spine, I think we can stop on T12. Actually, T12 is like a vertebra between thoracic and lumbar. If I saw well in the picture, I think there's
This is T12.
This, yeah, which one? Yeah, so I would stop. No, not this one is not T12. This one is T11. The T12 is just below. This one is T12. Look
Yes.
to the left. So I would stop on T12, but this one is T12, just below the end, the lower, the yellow line, just below it. I don't know if you want to call it L1 or T12, but there's a rib on the right side. You can see it, and I think this is T12.
Because this is the touched vertebra.
Yeah.
Yes.
Which is that there's a small rib on that side. So yes, I was labeling that T12, and if that's touched, that's where I would go as well.
So just to be sure on which we are calling T12. So I think the one just below the yellow line.
Yellow line.
Yeah.
So this was the same as whatever you call it, T12 or L1 or T11, whatever it is. So that is where we went to. And this is the follow-up X-ray. But we did stop at T4. We didn't go up to T2. And I will show you next a very similar case. In this patient, the shoulder is well balanced, and this is the post-op. There is not much of proximal junctional kyphosis. So this is the pre-op, and this is the post-op. So we brought it from 60 degrees to 12 degrees, and a reasonably good thoracic sagittal profile. And you can see that the lumbar hyperlordosis also has got corrected, because I forgot to measure this. This comes through from 49 degrees to about 30 degrees, 32 degrees in the thoracic spine. So the object of presenting this case is to introduce you to the next case. This is the pre and post-op clinical pictures. So the case 2 is a similar case. She's 15, again 2 years post-menarche, and this is her clinical picture. And as you can see that there is a large rebound and a significant trunkal shift also, because the arm trunk distance on one side is asymmetrical. And if you look at the PSIS, possibly this left side is a little bit higher than the right. And the left medial shoulder, the medial shoulders are level, and the lateral shoulders possibly about a centimeters up and down. And this is her X-ray. It's not a typical, I wouldn't say it's a rule breaker, but this is not a very typical Linky 1 or Linky 2 curve with the apex coming down to T11. The Linky in the major thoracic curve, it defines as anything with the apex can go down to T11, 12 disc. So this is possibly something like that. And on flexibility views, on testing flexibility, you see the 37 comes down to 21, and the 42 comes down to 17. It's pretty straightened up there. I'm not sure whether this is often seen or not, but it's not very commonly seen, at least in my practice. And this is where it was level. And for this curve, this was the traction film, and this is the bolster film. So 83 degrees coming down 36, and on traction it is 54. And the traction film also, this gets well stacked up from the proximal T1, T2, T3. They're all horizontally placed. So here, what would be your UIV and LIV? I'll go back to the X-rays once more. So if we have this, so the participants first, Samir, or yeah,
So
let's have a round from the participants, then we can ask the panelists.
4. Okay. Anyone else? From these, the debate here between from dorsal 4, all the audience here are with dorsal vertebrae fold to L3 and L4.
4 to 4.
Another colleagues is from T2 to L2, L4, T2 to L4.
So 2 to 4 or 4 to 4. So
some of them like this and other like this.
Okay, so that makes AIS interesting. Ibrahim, is it what are the levels for you?
Yeah, I will be shorter than the approximately. I would do T5 to L3. I don't know. I don't think that we should go to L4. So L3 will be okay, even if it is not touched by the medial sacral line. In these cases, especially, I think in the thoracolumbar, it's like it's more. It's like King 4 type. So it's King 4,
Yeah.
and then King 4 we should.
Yes, it is. Yeah. So T4 tilts. I agree with you, Ibrahim. So this is one type of curve. I don't think the Lenki classification covers it fully,
exactly.
because L4 tilting to the right, I don't know what Baron would say, but in my experience, I have not found a typical King type 4 equivalent to Lenki's classification, because in King type 4, L4 tilts to the convexity of the curve. And there are some long lazy curves in which L4 gets tilted, and there becomes, it's a difficult problem whether to stop at L3 or L4. For example, here, this is L4 and this is L3. So if you look at the touched vertebra, the substantially touched vertebra would be L4, but L3 would possibly be the just touched vertebra. So Baron, over to you.
Yeah, this is one of those that I'd worked very hard to avoid going to L4. And I think there's enough flexibility, particularly on the traction X-ray. And, you know, the curve is the fractional curve below is really, you know, that L3 is kind of rotated to the opposite direction, and it untwists very nicely on traction and the fulcrum bend pretty well. Sometimes we'll do convex disc releases, you know, either from an anterior approach. I think that's maybe too much to do here, but you can do it even from a posterior approach with a T-lift. We call them posterolateral convex disc releases. It may not even be necessary, but I think you probably can get to L3 with posterior column osteotomies and care taken to derotate the lowest instrumented vertebra. Proximally, I agree, you probably don't have to go all the way up, but I would probably kind of split the difference in maybe T3 on this case. Not quite as high, but I worry a little bit about the left shoulder. Just a quick comment on your last case, and that worked out very well. I think the reason that worked out so well for you and not including some of those kyphotic segments is she had a very high pelvic incidence. And so she's curvy by nature, and I think that's the way she wants to be. And you put a lot of kyphosis into your rod and into your correction. I think that's why it worked out well. So we're going to have to come up with a formulaic approach with a formula to understand pelvic incidence and how that plays into the sagittal plane in the thoracic spine. So great case.
So Baron, for this case, the sort of underlying message is that we can control the parts which we are instrumenting, but the parts of the spine which we are not instrumenting, they have their own mechanisms to adjust. And I think science has not brought us that far to understand the ways and means how the rest of the curve behaves.
Yeah, and there are factors that are out of our control, but I think if you were sensitive to her innate sagittal morphology, basically the pelvic incidence being high, and I think that's why it worked out.
So in this patient, just before moving on to the results, Baron, so if you stop at T3, wouldn't you be stopping at the apex of the thoracic curve? And is that a rule breaker?
Well, it's not really a rule breaker because many years ago, Mark Asher kind of did some work on this in Oheneba Boachi. It's really not a structural curve. So if it were structural, I would not start the fusion at the apex, but this is not structural. And I'm just trying to, be attentive to the shoulders and not to throw the shoulders up. I worry about a T5, but you may very well get away with it because there's enough flexibility there. But in my practice, we kind of split the difference.
Great thoughts, Baron and Ibrahim. I'll just go on to the result because I think we would be running short of time. So this is what we did. We did follow what Ibrahim said, T5 to L3. And initially she was a little bit tilted to the right, as you can see. And this is her initial pictures, pre-operative and post-operative. And 83 was brought down to 23. And this is her initial pre-operative, in which you see the left shoulder was a little bit up, but her arm trunk distance and the pelvis symmetry was much better established with a rib hump correction, which was quite nice. And this is her at 24 months follow-up. That is 24 months follow-up. So she's very nicely balanced so far as the lumbar curve, but you do definitely find T1 tilt, which is there. So this curve did not behave as expected, that they will line up one over the other. If you can look here at the preoperative, we've left them about 5 degrees, given them 5 degrees more of a tilt on the lateral, on the final follow-up at 2 years. Though the sagittal profile looks great, and she is personally quite happy, but your comments, Ibrahim, and then Baron.
Yeah, I think I would do exactly the same as I told you. And the fact that the coronal malalignment worsened immediately after surgery is very, very well known. We already described it in the adult in our classification, and that is the type 2A1. And after surgery, we will have a worsening, and with time we will have an improvement related to the flexibility of the lumbosacral junction. So it's something very, very classic. Concerning the upper part, actually, for me, I always try to measure the advantage of fixing until T2 or the advantage of leaving totally the upper curve. I don't like to stop in the middle of the upper thoracic. So I decide to go to T2 or T1 if the curve go there, or I try to leave it completely. And one of the factor is the presence of kyphosis between the two curves. So in this case, it is not kyphotic. The angle is low, so it's not like 40 or 50 degrees upper thoracic. So for me, I prefer to have a small amount of imbalance of the shoulder than to have a painful upper thoracic part, because we know that the fixation to T2 create, and we have now we saw many papers on that, on the pain of the upper thoracic part. And if I can leave it, I will finish on T5 to avoid that.
So if it was your daughter, Ibrahim, you would take this as a good result?
She's perfect. For me, she's perfect. 1 centimeter from the shoulder is nothing comparing to fix 4 more vertebrae.
And before we go on to the last very short case, do you feel that patients whom we go up to T1 do have some residual neck pain from 3-4 years down the line? They do complain of neck pain?
I think she would complain of more of neck pain if we fix until T2, more than if we leave 5 vertebrae. I think really the result is good. We should compare her status before and after surgery. This is what we should not only focus on 1 centimeter from here or from here. Look to the picture of the patient, and the picture says everything.
Right. Thanks. The last very short, it's a rapid fire. It's a 15-year-old girl, and this is a typical Lenki 5C curve. As you can see that there is a lot of loin hump, and this is her. So the question is about the flexibility. So it's about 54 degrees lumbar, 20 degree thoracic. It's a Lenki N, possibly with 26 degrees of T5 to T12 sagittal cob, and the thoracic corrects down to 7 degrees and the lumbar corrects down to 26 from 54. So it's pretty flexible, 50% flexibility. And on traction films, that's 28 degrees. I don't think we'll go on into which is better, traction or a bolster, but let us talk about UIV and LIV. From the audience summit, UIV and LIV. This is 12 and this is 11. Some of you are there. Are we live?
Can you hear us, sir?
Yes.
Okay, we lost you for a couple of minutes.
Yes.
Would you please start this last from the beginning?
Yeah, so this is a rapid fire last case, which is a 15-year-old girl, and so this is her clinically with a left-sided loin hump with a reasonably balanced shoulders. As you can see, there's a typical asymmetrical abdominal crease and asymmetrical arm trunk distance, with a possibility that this PSIS is a little bit higher than this one. And this is her standing x-rays. 54 degrees lumbar, 20 degree thoracic, 26 degrees of sagittal cob, T5 to T12, and this is correcting down from 54 to 26 degrees on the bending films, and the 20 degree thoracic corrects down to virtually 7 degrees, which is becoming straight. And so what is the UIV and LIV? Quick round from the audience before we ask the panelists and close it for Chris to take over.
Could you please show us the X-rays again? Sir, could you please show us the X-rays again?
This is the X-rays. These are the X-rays, and these are the bending films. So 54 to 26, and the thoracic curve correcting completely. This is the bending. This is the traction.
Yes. Yes. Okay, perfect. Now we see them.
And this is the standing whole spine AP and lateral, 54 degrees, Lenki 5C curve. It is T12 to L4. So have we lost them, Samir?
No, we are here debating. We're debating on the selection.
Okay,
of elements.
okay.
L4.
Can we see the bending views, please?
Yes, please. Yeah.
Posterior. الطابق.
The structural junction is kyphotic. I will support the curve even if it's non-structural numerical, as you can see. So I will go from up T4 to 5 to L4 down.
Well, T4 to L4. This seems to be the consensus here.
T4 to L4.
Yes, but some opinion on selective lumbar fusion and stopping at T10, but the majority are with T4 to L4.
So Ibrahim, what would be your take on this?
Amazing. Actually, I do not agree with your COB limits. I think it is T11 and L3 the COB limits, and not T12 L4.
I agree.
So okay, so
This is T11, yes.
yeah,
You're
T11
correct.
and
Yes.
L3 and not L4. Look to the disc L3 L4. It is opening from the other
Yes.
side.
Yes.
So I think I would do only T11 L3 fusion.
So you will go up to here or you will go up to here? This
T11
one,
L3.
that one. Lower one, this one,
This
or
one.
that
Yes.
one?
No. This one is L4.
This
This
one?
one, yes. Yeah, this is the limit of the COB angle. It is your blue line, your yellow line is not good. You should
Yeah,
put
so-
it here.
Yeah, do you think that
Because
this
the-
rotation of L4 is good enough to derotate if you stop at L3?
I think saving level in
Yes.
this case, and especially the L3, L4 level, is more important than the rotation we will keep after. And but the line, the yellow line, if you look to the disc above, it is closed from the left side and it is open from the right side. So it's below the curve. It's not included in the curve. The disc above, not you see what I mean?
Yeah,
This
I agree
one.
that this
Yeah.
yellow line could come up there. I agree.
Exactly. So I
But
would
it
do
is
cup to
very-
cup.
Yeah, but it's very difficult to actually find out the exact disk space opening on that side because the spinous process, because of its rotation,
Yeah,
tends to
but
overshadow.
still, it is open. It is open. We can see it.
Maybe. Agreed. What about Baron? You would go from so Ibrahim would go from T11 to L3, isn't it?
Yes.
So
Yeah, and what
I
about
would
Baron?
as well, but I would probably do this as an anterior approach because I think we're going
Exactly.
to get a much more powerful derotation and translation of the apex. I think it's very important to not leave the LIV if it's L3 off the midline because they're set up for, as I showed earlier, risk for disc degeneration. So I think anterior instrumentation fusion with really good annular releases and pushing it over, translating it over and derotating.
Right. So I think for the shortage of time, we just show I did posterior from T11 to L4, and this is her post-ops, and this is her pre-op and post-op together, and this is her 3 months follow-up, and this is her 3 months. I did not go anteriorly. I could have saved a level at L3 possibly if I went in anteriorly, but posteriorly L3 was too far away from the CSVL. So I prefer to go down to L4, and that is what it looked like. Any comments before I hand over to Chris to talk about error deformities?
She's got ligamentous laxity. So of course, even if you went to L3, I'd be concerned as well anyway. So this is going to give you a good stable outcome until she presents in her adult years with disc degeneration. So, but you didn't create the pathology. You're just trying to help her. So, but I really try to avoid L4 if I can.
Yeah.
Okay.
I totally agree with you. I was doing it too many anterior approach before, and it was really a nice scenario. In this case, is one of the rare indication that I keep now for anterior approach. I totally agree with Baron, yes.
Okay,
Thanks,
we are
Amin.
short on time.
I
Actually,
think
we have to end this
Yeah.
session to begin the second
Right.
talk with, we welcome Professor
Thanks.
Chris
Thanks,
Jeffrey.
Amin.
Yes, thank you. Thank you, Baron. Thank you, Brahim.